Hello, I'm Ibrahim Imam, and welcome to this edition of the Neurology Lounge podcast. In this episode, we'll continue our exploration of migraine. And my guest today is Dr. Mark Weatherall, neurologist and a headache specialist. And we'll be talking about his book, Living with Headaches, which was published just this year, 2024. The focus of the discussion will be his perspective of migraine, both clinical and treatment-wise. Mark Weatherall is a consultant neurologist and clinical lead for neurology at Buckinghamshire Healthcare NHS Trust, former chair of the British Association for the Study of Headache and trustee of the Migraine Trust. He was a highly regarded historian of medicine before studying clinical medicine at Cambridge, which is an interesting background. He had junior medical jobs in Cambridge, London, and Oxford, and he completed his specialist training in neurology in the northwest of England. He spent 12 months as a clinical research fellow with Professor Peter Goldsby and Dr. Holger Kauber of the Headache Group at the Institute of Neurology in London. These are big names in the world of headache. Dr. Weatherall is a fellow of the Royal College of Physicians of London and Edinburgh. His interests include the diagnosis and management of chronic migraine, facial pain, visual snow syndrome, and secondary headaches associated with systemic disorders. He's also interested, understandably, in the historical, social, and cultural aspects of headache and facial pains. Furthermore, he has made presentations on these subjects at meetings of the International Headache Society, the European Headache Federation, the Migraine Trust International Symposium, and the Association of British Neurologists. Dr. Weatherall also led the development of the National Neurosciences Advisory Group's optimal clinical pathway for patients with headache and facial pain, and he actively promotes the importance of headache and facial pain disorders through social media and more traditional media platforms. And you'll add podcasting to that list today.
Yeah.
Mark Weatherall, welcome to the Neurology Lounge podcast, and I'm most grateful that you accepted my invitation.
Thank you very much, Ibrahim. I'm really looking forward to chatting about all things migraine and maybe a little history as well.
Yes, I'm very interested in that as well. But going back to basics, writing a book such as yours must take a lot of time. How did you go about writing it? And I know you're a headache specialist, but why did you write it? And it's a new book. You've been in the field for quite some time.
Sure. Well, I mean, obviously, with my background as a historian, and even further back as a sort of student journalist, I've always been a writer, and I've always enjoyed writing and found it relatively straightforward to write. And I know that's not something that everybody is able to say, but I do find it relatively straightforward and enjoyable. And I've been intending to write something in the field of neurology for a number of years, and had various ideas and a few books ideas that I pitched and hadn't quite come off. And then I was approached by the team at Headline to ask if I would be interested in writing a book about headaches. So they were looking to start a new series on common health problems, and obviously, as we all know, in neurology, the commonest health problem in neurology is by far is headache, and the most common debilitating headache is migraine. And so they asked if I would do that, and they essentially gave me the task of working out what people would want to know about headaches, what people living with headaches would want to know, what people caring for people living with headaches would want to know, and what my colleagues who maybe were not headache specialists would want to know, and trying to incorporate that within the book. And so that's how the idea came about. And of course, with all of these things, it took quite a bit longer to actually get it all down on paper. But in the end, it was done, and yes, published just at the beginning of this year by Headline.
Great. It's difficult pitching anything to a specialist and a general audience, which is a challenge I face with the podcast. But clearly, that was the reason I picked on your book. It's this broad approach. Very early on in the book, you made the distinction between primary and secondary headaches. And the difference you said was whether there is actual or potential tissue damage. What do you mean by this? This actual.
Well, this sort of goes back to the IASP definition, the International Association for the Study of Pain, and they have this actually, I think, really quite well thought out definition of pain as being the experience that is related to actual or potential tissue damage. Now, of course, the difference between primary and secondary headaches. Primary headaches are headaches that we experience just because that's the way our brains work. And of course, the commonest primary headache is tension type headache, a mild ache that most of us get. This doesn't cause us too many problems. And of course, the most common debilitating primary headache is migraine, which I'm sure we'll talk about at length. So these are conditions where we feel as if there may be damage to tissues. People with migraines or cluster headache or other severe headache disorders will experience or will say that they have an experience of actual damage to their brains, and people are very worried about the fact that their brains may be damaged when they have severe headaches. But there is no actual damage. It's just a network of activity that gives us the experience of pain, as opposed to secondary headaches, which are headaches where there is pain that arises from some pain-sensitive structure in and around, usually in and around the head and the neck. So the sinuses, the jaw, the neck. And of course, in those situations, there may not be actual tissue damage, but there is stimulation of pain receptors. And again, pain receptors are stimulated either by actual damage within the tissues or by the threat of damage. Pain is a protective experience. It is supposed to elicit a response that protects us from actual tissue damage. So the fundamental distinction between primary headaches and secondary headaches is really the nature of where they come from and the potential for there to be actual damage to the tissues in situations where there is secondary pain.
And such sinister things as brain tumors, those would be secondary then, obviously.
Yeah, so these are the things that people worry about. Of course, one of the ironies of headache medicine is that there is this curious dichotomy between people's views of headaches as being either something that are trivial, everybody gets headaches, and if people complain of headaches, then they're just making a fuss of nothing on one side, and on the other side, that they're incredibly serious and they can be the harbingers of doom from aneurysms or brain tumors or such, very serious problems. And of course, the reality is that most of the time, headaches are neither trivial in terms of the effect that they have on people's quality of life, nor, fortunately, are they sinister in that they have a serious underlying cause. Of course, in some cases they do, and it can be difficult to pick those out from the types of headaches that actually are much more benign. But there are usually clues in the history, in the examination, in the nature, the pattern of what's happened to people, that certain headaches may be much more worrisome than others.
So you're talking here about kind of red flags for sinister headaches. What should one be worried about?
Well, fundamentally, most episodic headaches, most headaches that come and go and resolve completely in between times, are primary headaches, and they're generally benign. So, recurrent dull, mild headaches, they're probably tension type headaches. Recurrent headaches that are more severe and make people feel a bit sick, or they don't like lights or noises, they're probably migraines. Nasty recurrent headaches that wake you up in the middle of the night and your eye waters and you pace around the house, they're probably cluster headaches. Now, they're very unpleasant, but they are fundamentally benign. Headaches that start one day and don't go away are perhaps more worrying. Now, they're often benign as well. They're often chronic forms of those primary headaches that we've already mentioned. But clearly, that scenario of a headache that just starts and just gets worse and worse and worse is something that could potentially be associated with serious underlying pathology, whether it's a tumor, whether it's systemic inflammation. One thinks about conditions like giant cell arteritis in the elderly and so on. So that's a sort of worrying scenario, or can be a worrying scenario, or at least a scenario that warrants attention. A thunderclap headache, a sudden headache that comes on, within a few seconds to peak, again, that can be a worrying scenario. That can that can indicate, intracranial bleeding or some other serious pathology. And obviously, if people have headaches and they have focal neurological symptoms or signs, then again, these are situations where, again, this warrants attention. And of course, many people with migraine will have, symptoms that may raise the possibility of more worrying neurological conditions such as stroke. And often, actually, these people do need to be investigated, and you need to have scans just to make sure, actually, that this is, in fact, all migraine.
The scenario, I think the older I get in the business, the more you get this scenario where you've taken a good history as a neurologist or a doctor, no red flags whatsoever, but the patient is there waiting for you to fill that form for an MRI scan. How do you tell them no? I think it's
well, I think it's very difficult to tell people no, because it's such a pervasive trope within literature, within in cinema, within society as a large, and it comes back to that curious dichotomy of headaches as either being wholly trivial or very sinister. And when it's when there's it's out there in films and television, it's such a common thing. The character starts getting headaches, and then eventually it all turns out to be a tumor, and it's doom and gloom. So I think it's very difficult to persuade people. If people are determined that they want a scan, it's very difficult to persuade them not to have one. I think what I often do is say to people, if I have concluded that, that they probably don't need to have a scan, and most people really don't, that I would say to them, look, I don't think you need to have a scan, but I would never try to persuade them out of it if they were determined upon it. But I would point out, for example, that if you scan people and you expect the scan to be normal, about 2 or 3% of the population have got odd brains. They've got little cysts or little benign growths, and you may well find things that cause anxiety and cause other problems if you're actually expecting everything to be normal. So I think it's a difficult conversation, but I tend to find that if you explain the rationale, and lots of people are relatively happy if you can explain to them why their headaches are not serious and not an indication of a tumor, then a lot of people are actually perfectly happy not to be scanned. The problem is if you don't scan people in that who are desperate to be scanned, then they're almost certainly going to end up coming back, either to you or to someone else until they've been down that line. But the problem with that is that we know from some really nice work that was done 20, 25 years ago by Tim Steiner and colleagues that scanning people to allay anxiety only works temporarily unless you can actually then give them a proper diagnosis and treatment plan. So you have to come back to that at the end, because otherwise just scanning them and saying, look, it'll be fine, it will all settle down, that doesn't work, not in the long term.
Well, thanks for putting all that in context. We'll probably hone down on migraine. You discussed 14 primary headaches, but clearly the book you focus a lot on migraine. You've indicated is the commonest, most debilitating primary headache. Why does it stand out in that regard? Why is it that common, and why is it that debilitating out of 14 other headaches?
Well, so, obviously, it's not the most common primary headache disorder. Tension type headaches are more common. Virtually all of us get them at some point during their lives. But migraine is incredibly common. 30% of women, 20% of men will get migraine at some point during their lives. And migraines, by nature, by definition, are more severe. They're moderate or severe headaches. And they're associated with a lot of other features. So people feel nauseous, they may find lights and noises, make the pain worse. At their worst, migraines can render people completely bedbound for days at a time. And of course, you then have a quarter of people with migraine who experience transient neurological disturbances in the form of aura. And again, usually visual, the sort of flashing lights and blind spots that people will experience. But those auras can be more severe. People can get sensory aura, people can become dysphasic, people become hemiplegic with auras or even pass out. So migraine is by nature a much more debilitating experience. And if you then sort of add into that fact that actually about 1 or 2% of the population suffer from chronic migraine, which by definition in the migraine world, chronic is all about high frequency, so headaches more days than not, then actually there's an enormous individual and societal burden from migraine, which is why it is really the most important primary headache disorder. Now, of course, cluster headache, which is the third most common primary headache, is not that uncommon. I mean, it's got a lifetime prevalence about 1 in 200. Most GPs will have several patients on their books with cluster headache. And of course, the other primary headache disorders are much less common. And, whilst fascinating to headache interested neurologists like myself, are very much small print and much rarer. So migraine, if people have severe debilitating recurrent headaches, then they've almost certainly got migraine. And that's really why, I concentrated in this book predominantly on migraine, because actually most of the people who suffer from recurrent headaches, actually the condition they're suffering from is going to be migraine. And that's why, it was really the focus of the book. And it's the focus of, so much of the work that one does, as a headache neurologist.
A couple of things about migraine, which you discussed. One, going back to its origin, coming from the name hemicrania, it's a one-sided headache. And we see patients coming in and saying they don't think it's a migraine because it's not one-sided. How did hemicrania become migraine? And how did this perception of a one-sided headache become so entrenched, which I suppose is wrong, isn't it?
Well, I think it's not wrong, but it's not the whole story. So, I mean, the kind of linguistic derivation, as you rightly say, comes from the original Greek word hemicrania, which just means half the head. And if you go back to the ancient literature, if you look at the kind of the primary authorities such as Galen or Areteus, they talk about various types of headache, but one of the real characteristics that they mention a lot of these is these one-sided headaches that people get. And there are descriptions within those works that were written 1800 years ago now, which would be instantly familiar to anybody that kind of talks to people with headaches in the 21st century. Over time, I mean, the kind of the elision from hemicrania to migraine sort of happens in Old French, and that first sound is lost, and hemicrania becomes migraine, becomes migraine over time. And of course, the meaning of migraine, changes over the period from the Middle Ages to the 19th and 20th century. So our sort of current modern understanding of migraine sort of evolves over that sort of whole period of time. And of course, it has become, if you like, sort of more set in stone with the advent of the sort of international classifications. Firstly, the American ad hoc one in the 60s, and then the International Headache Society, various iterations since the 1980s. Now, that, of course, was one of the most characteristic things about migraine, was that it was often a one-sided headache, but it doesn't have to be. And many people with migraine get, headaches at the front of the head or the back of the head or over the head, or even pain that predominantly is felt in the neck. And actually, some people get migraines where the pain is predominantly in their body. Migrainous corpalgia, it's very unusual, it's very rare, and as you can imagine, it's quite tricky to diagnose. So yes, it's often one-sided, it's often a throbbing headache, but it doesn't have to be throbbing. But the characteristic of migraine is that it's a severe headache. They're bad enough to stop you doing what you want to do. And it's the other features. So if you look at the sort of overall studies of migraine and the various associated features that have the highest specificity and sensitivity for diagnosis, then the two things really that come out time and time again are nausea. So, do you feel sick with your headaches? Yes. Okay, they're probably going to be migraines. And photophobia. Do normal levels of light make your pain worse? And those two things. So actually, there are diagnostic toolkits that say actually all you've got to do is ask people three questions. Do you get severe headaches? Do you feel sick with them? And are you sensitive to light? And if the answer to any two of those is yes, then those people have got migraine. Now, there's a bit more to headache neurology than that, but actually, those are the features. Those are the cardinal features. In the same way that the cardinal features of Parkinson's are bradykinesia and rigidity and resting tremor, but not everybody has all of them. It's the same for migraine. That recurrent severe headaches, nausea, light sensitivity. People have got that triad, then they've almost certainly got migraine.
And the concept of a migraine starting in the neck, it's
so the neck is, the neck is so controversial. And I jokingly say in the book that if you find yourself at a party sort of cornered by two headache specialists, and what sort of party is that? But if you did, then, and you wanted to make a quick getaway, which of course you would, then the best thing to do is just mention the neck, and then they'll start arguing, and you can kind of slip away while they do that. I think there are many people in who are interested in headaches who believe that the neck is the kind of the font of all headache disorders, and pretty much all headaches come from the neck. I think that's manifestly not the case. There are other people on the other side, and my old boss Peter Goatsby, was one of those who said, look, actually nearly all the neck pain that you get associated with migraines is actually caused by migraine. It's a consequence of migraine. Now, I think the truth, as always, lies between those two extremes. The neck is very important because sensory information from the neck, C2, C3, C4, feeds into the bit of the brain that is activated and starts to generate pain experiences in migraines. So this bit of the brain called the trigeminal-cervical complex. It normally processes sensory information from the trigeminal nerves that supply the front of the head and the face, and the high cervical nerve roots. And I think there's an idea that from an evolutionary point of view, it makes sense that there will be one part of the brain that would deal with sensory inputs coming from the whole of the head and the neck area, because again, as a protective instinct, if you are being threatened anywhere in the head and neck area, then you need to respond very quickly. And actually, it doesn't really matter too much whether it's coming from the front or the back. So that is a single area, and it takes input from all of these places. And functional imaging, a lot of electrophysiological studies clearly demonstrate that one of the initiating features in migraine attacks is activation in that area. So in a lot of cases, you have a scenario where people have a propensity to migraine. You sit down with somebody, you say, well, is there anybody in the family with headaches? And you get often a family history of a parent or two parents or grandparents or aunts or uncles with headaches, with migraines. And you may get a personal history of some of the things that happen earlier in life. So, abdominal, repeated, abdominal pains or vomitings in childhood, which again, we know are childhood precursors to migraine. And then, then you get a sort of maybe a history of kind of quite classic sort of migraine with auras in their teens or 20s. And then as people get older, we all get wear and tear in our neck. And for most people, that just causes a bit of pain in the neck. But if people have that migraine biology, abnormal sensory inputs from the neck potentially can feed into that bit of the brain and can drive migraines. Of course, then you get this vicious cycle because you get more migraines. The migraines cause more neck stiffness and neck discomfort. The neck gets stiffer, it gets sorer. That drives more migraines. So very often when you see people who have chronic migraine, they also have long-standing issues with the neck. And one of the keys is to recognize that and identify that and try and find ways of actually improving, the neck per se, because even though that's not the fundamental cause of their headaches, it's a really important part of what keeps that whole cycle going.
That explains why some of my patients ask for an MRI of their neck as well.
Yes, and of course, it's a bit like doing an MRI of the brain. If you know what you're going to find wear and tear, because we all have wear and tear. And most of the time, the issue is not something that really comes up on an MRI, but it's mostly to do with the kind of soft tissues. It's mostly to do with the kind of the muscles, ligaments. And a common scenario is entrapment of the occipital nerves, the nerves that supply the scalp, that feed backwards, curve around the base of the skull, and they're very, they're quite vulnerable there. At that point, they can become entrapped and inflamed as they go through those muscle layers. It's sort of like carpal tunnel syndrome of the head. But again, that could be a very important thing to recognize and to treat when you're trying to sort of calm down a system that's very overactive and is sort of kind of gets engaged into these vicious cycles that keep headaches and migraines going.
Migraine has a tendency to pull in very different directions. I'll try and focus on something you've mentioned twice now, which is central to migraine, which is the aura. An interesting phenomenon you explored extensively, and then you yourself have personal experience of migraine aura. Do you tell us what yours are like?
Yeah, so I mean, mine are pretty sort of classic visual auras, and I mean, my first experience of this was, as I sort of described in the book, was at about the age of 14, kind of, playing cricket in the garden and chasing after a ball, and suddenly realised I couldn't see a little bit of my vision, and what I developed then, and what I have continued to have on and off ever since then, is sort of very sort of classic sort of small shimmering dot that then starts to expand into a sort of crescent with a kind of shimmering, slightly zigzaggy outer edge, and just a sort of for me a sort of fairly narrow sort of scotoma just behind it, and clearing from the centre, and that sort of goes out. And in my case, as it sort of goes into my peripheries, it becomes kind of more extensive and actually a little bit more uncomfortable. There's almost like a sort of strobe effect, which is a little bit uncomfortable, just in terms of visual, stress. And then it just sort of clears out of the vision completely. And in my case, it typically takes about 15 or 20 minutes. When I was young, as a teenager, I would then get a severe sick headache afterwards. And I remember a particular event, and this shows both my age and what sort of teenager I was. I went to a cinema showing of all 3 Star Wars films in order, and I got a migraine halfway through Star Wars, completely missed The Empire Strikes Back, and kind of came to halfway through Return of the Jedi, which was a real shame because I missed the best film in the trilogy. And but it was that was the sort of thing that I would have. And then again, interestingly, I stopped having those when I was about 20. And I didn't have another migraine aura until I was in my late 30s. And I had a single isolated one. And then about 10 years ago, I had a 6-week spell one summer where I had 12 or 13 episodes within a short period of time. And even I was starting to get a little bit, not sure what's going on here. Maybe I should have myself scanned. And then it all settled down completely. And I've had a couple since then. So it's migraine aura. It's quite capricious. We talk about triggers, we talk about lifestyle things. And, these are really important for a lot of people with migraine. But in a lot of cases, that goes more for people who get migraine without aura. Aura has a bit of a life of its own. It comes and goes. And, one does see a lot of people who get these flurries of recurrent episodes of aura over a short period of time. And, usually, 99 times out of 100, when you investigate those people, because you often end up doing that, you just never really find anything. And it is just migraine doing what migraine does. So aura, I spent a lot of time talking about aura in the book, and I think this is one of these things that people who write about migraine do this. I mean, Oliver Sacks's sort of seminal book on migraine that he wrote back in the late 60s, early 70s. He concentrates a lot on aura, and I think as neurologists, we get very sort of fascinated by all the extraordinary things that aura can do. But I think it is really useful to actually put that down on paper, because a lot of people experience these things and do get very worried about what these experiences actually mean. And people do worry that they're having, mini strokes, or that they've got, MS or some other condition, because they've got these visual disturbances or these these odd tinglings that sort of spread up and down one side of the body, or even in the sort of more extreme cases, people that end up going into hospital thinking they've had a stroke because they've just gone weak down one side. So actually, putting people's experiences down on paper and saying, look, these are the sort of things that migraine can do. And yes, of course, sometimes you need to look at this carefully and make sure that it really isn't anything else. But actually, is that outside the envelope of what a migraine experience can be? And that's a really useful thing, I think, to reassure people, to be able to say, look, I've heard that before. People have told me that before. I've seen people with that particular experience, and actually, yes, it can all just be migraine.
And you talked about the different types of migraine: visual aura, kaleidoscope, broken vision, blind spots. Why does the aura come in so many different forms if it's all visual?
Well, I think it's because of the differences in the kind of in the areas of the visual cortex that are affected. So the aura process is, I think, now universally understood to be cortical spreading depression. So this is a physiological process first discovered by the Argentinian physiologist Aristides Liao back in the 1940s. And what you get is a wave that crosses the cortex at about 3 millimeters a minute. And what you get is a peak of over excitability. So you've got overactivity in your neurons for a period of time. You've then got a period of silence, of neuronal silence, and then you've got a resolution. And if you record that experimentally, with a series of EEG, dipoles going forward, you see that process spreading forward. And Liao himself sort of suggested, well, look, this might fit for migraine. And again, the Canadian neuropsychologist Peter Milner in the 1950s again kind of raised this as a possibility. But I think it really wasn't until the 1980s when the Martin Lawrence and Jens Olsen, the Danish group, kind of showed spreading oligemia that crossed the boundaries of different kind of areas of blood supply. So therefore kind of debunking the model that aura was due to somehow to constriction of the major blood vessels. Never really made sense, but they absolutely proved that it wasn't. And then more recently, in models, you've seen those sort of aura, cortical spreading depression processes occurring. So that's the physiological substrate of this. That's what's happening, at a sort of cellular level. What our experience of that is depends on whereabouts in our brain, in our cortex, that starts, and how that affects those bits of the brain. So, fundamentally, clinically, what you're looking for with migraine aura is a combination of positive and negative features. The flashing spots, but also the scotoma, also the blind spot. If people get sensory aura, then you're looking for kind of tingling, but also numbness, and again that sort of sense that things are spreading steadily over a sort of minutes, and what exactly happens depends really, exactly whereabouts in the brain those processes are occurring. So there is a predilection for the occipital lobes, for the visual parts of the brain, for reasons that I don't think anybody really still understands why the visual, cortices are particularly prone to this. But if that process, keeps on going, or it starts a bit further forward, then you hit sensory cortex or language areas of the brain, or even motor areas. So aura as an experience is protean. It can do so many different things. But I think physiologically the reason is it's the same process, but what we experience depends exactly where it is in the brain. And I think, there's been one or two beautiful kind of studies. One of the American groups did a fantastic, study where they were kind of, recording people's, they had a particular patient who recorded their aura really carefully, and they could actually map what that patient was drawing to, specific cortical areas. And of course, a lot of our cortex is relatively silent in terms of our experience. So again, it's not surprising that, that sometimes aura is fragmentary. Sometimes there is, both visual and sensory disturbance. It's a complex, it's not a sort of straightforward thing. It's very difficult, can't straightforwardly map the visual world out there onto, the cortex in here, like a pinhole camera. It's obviously much more complicated than that. And that's one of the reasons why aura is such a sort of varied experience for different people, and also for individual people within their own kind of migraine life.
We can have a whole podcast on the aura, but I still have a couple of questions based on it. One, does it mean an individual can only manifest one type of visual aura, or can you have the different visual auras in one person?
I think generally speaking, people, we often, when we're sort of thinking about epilepsy, we're often looking for people to have very stereotyped episodes, and that's something that makes us think, yes, no, okay, this is a specific focus, and this is migraine is often, yes, for a lot of people, their experience is very sort of standard. So, if they have an aura, it's likely to be the kind of same sort of thing. But for example, many people will have that sort of expanding, the fortification spectra, that expanding crescentic kaleidoscope type picture. And 95% of the time it will happen, in their right visual fields, originating from the left hemisphere. Just that one time in 20, it happened on the other side.
Okay.
Sometimes, that process, that again, for reasons that are not understood, that process usually peters out within the occipital cortex. But if it keeps on going, sometimes people may have, their typical visual aura and then get a sensory disturbance and then become dysphasic. So, most people who experience aura over the course of a lifetime, there's often an evolution, but it often has kind of themes, and people will normally recognize their auras. But you do have situations where people suddenly get something very different, and of course that, again, that can be that can be very disconcerting, and that can bring people to medical attention when they suddenly have something different. So people can certainly have different types of auras. That's perfectly common, but often there is a sort of theme to it, and often people have, relatively similar experiences over the course of a lifetime. And of course, one of the most common patterns is that when people are young, they will have aura, and then they will have afterwards a very severe sick headache. And then as they get older, they will continue to have episodes of aura, but headaches will often kind of settle away. And, in old age, people often continue to get aura well into later life, but actually don't get much of a headache with it.
That's migraine for you. One last thing on the aura, which you explored in the context of the Alice in Wonderland syndrome. I know that migraine is not the only thing that gives this, but what is the Alice in Wonderland syndrome? And is it a manifestation of the migraine aura or something different?
Well, I think, as you say, migraine aura is one of the potential underlying causes of that experience. So Alice in Wonderland syndrome was a term that was coined for experiences of distortion of body image. So that feeling that part of one's body is either much larger than it should be or much smaller than it should be. Now, of course, the name was given because in Alice in Wonderland, in Lewis Carroll and Charles Dodgson's book, Alice has these experiences where, she becomes much bigger and much smaller by, drinking the potions and eating the cake. And the speculation is that we know that Charles Dodgson, Lewis Carroll, had migraine. We know that he did because he writes about it in his diaries, and we know that, for example, he read Peter Latham's lectures on migraine that were delivered at Adam Brooks in Cambridge in the 1870s, because he writes about that in his diaries. And so people have sort of speculated that maybe some of these kind of slightly psychedelic experiences that he put in the book may have related to his own experiences of disturbances of body image with migraine. I mean, actually, I think the most bizarre kind of Lewis Carroll speculation is that the Cheshire Cat, I don't know if you remember, that the Cheshire Cat sort of sits on a branch and then starts to fade away, and eventually it's just all you can see is the grin, and you can see is the smile before that goes. And some people think that's a kind of scotoma, but that's maybe pushing it a bit far. So that's how the syndrome got its name. Now, of course, the presumption is that within a migraine scenario, what's happening is there is that process, that cortical process, is affecting those bits of the parietal lobe that kind of give us our sort of sense of self, and that there is a temporary kind of derangement of that. And of course, that has been, people have there are other pathological processes, epilepsy, stroke, and neurodegenerative disorders that have been reported to kind of create the same sort of thing. But obviously, migraine can do so, but in a temporary, reversible manner. So it's a fascinating thing, and I mean, one of the interesting things about Alice in Wonderland syndrome is it does seem to be more common in children than in adults, and it is the sort of thing that when you talk to people who have had a lifelong experience of migraine with aura, not infrequently, if you kind of delve into their experiences, they will say, "Oh, yeah, well, when I was a child, I used to feel like this," and then it seems to become much less of a thing as people get older, which I don't think anybody's really kind of explained why that is. But it's a sort of it's one of these sort of, again, these many sort of interesting observations and sidelines that you get from talking to people with migraine.
Fascinating, as you said, but coming down to earth, migraine with aura is not the commonest form of migraine. Is that a point we should make? It's most people.
Yes, no, I mean, only about a quarter of people with migraine get aura, and I think this is, there's a number of reasons why people get a misdiagnosis, and I think one of those reasons is that there is still in some quarters, an idea that it can't, unless people get aura, it can't be migraine. And so, yes, it's very important to point out that, 3/4 of people who, experience migraine do not get aura. They get, severe recurrent headaches associated with nausea and sensitivity to lights, noises, movement, and so on. So yes, the presence of aura is helpful in a diagnostic manner, but it is, yes, it's by far, well, it's not by far, but it's much less common for people to experience aura than it is not.
And then photophobia or light sensitivity being more common. You mentioned the underlying pathology being some connections between the retina and the thalamus. How does that kind of play with bringing this light sensitivity?
So I think this is one of the most interesting pieces of research that's been done in the last 25 years about migraine. And this was done by Rami Bernstein, who's a migraine scientist who's based over at Harvard, and works with teams at Mass General. And what they were doing is that they were talking to people with migraine that had been born sighted, but then had become blind. And those people still experienced photophobia. In other words, that is worsening of their migraine pain by exposure to normal levels of light. And so they were trying to understand how this could be when they were blind. And what they showed was that there are direct connections between the retina and the thalamus. So there are direct retinothalamic connections, which they demonstrated in suitable animal models, and then kind of demonstrated insofar as it was possible to do so that these connections are likely to be present in humans. And they postulated that these direct retinothalamic connections are actually part of a defense mechanism. So essentially, again, if one is exposed to very bright light, this is what people experience pain. There's a pain sensation, and again, that's a protective sensation. In the same way that if you put your hand on a hot stove, or there's a sensation of pain, and that's supposed to protect you from tissue damage. The same thing. Exposure to over bright light can damage the retina, so that creates a pain response, and that's thought to be modulated through these retinothalamic pathways. In migraine, what's happening in migraine, we mentioned earlier on about this trigeminal-cervical complex, which is kind of deep down within the brainstem. And that's normally very active because our bodies are constantly getting sensory information from the head and the neck and the shoulders and so on. Most of the output from that area is kind of just kept under control by descending pathways from higher up in the system. In migraines, that whole system kind of starts to run hot and actually override those control pathways. And it may be, in fact, that fundamentally the genetic basis of migraine is the fact that those control mechanisms don't work as well as they should do. Signals start to come up, and the relay centers from taking sensory information from deep bits of the brain which are kind of working in the background and we're not aware of, to our cortex and the bit of the brain that tells us, oh, you're in pain. That relay station is the thalamus. And so again, the idea is that all of these sensitivities that people have in migraine, sensitivity to normal levels of light, normal levels of sound and touch, these are almost certainly modulated through connections that happen in the thalamus. And so, this normal input from this circuit is enough just to kind of give those migraine signals a kind of shove on their way up to your cortex and just wind everything up. So it's a really interesting piece of science, starting off from a clinical observation that these patients who became blind could still experience photophobia, and then working out why that might be, and then coming back and saying, okay, this is probably how it works with migraine.
Stretching that further, do we see thalamic deep brain stimulation as a treatment then for migraine? Is that in the cards? If the thalamus...
So, people have obviously, neurostimulation has been an area of interest in primary headache disorders. Well, and actually also secondary headache disorders, occipital neuralgia in particular, for about 30 years. And when I trained with Peter and Holger back at the institute, 20 odd years ago now, my very good friend and colleague Ryan Burns was doing some work on occipital nerve stimulation in cluster headache, and this was a kind of big area. DBS has been used for primary headache disorders, and there are various sort of targets that have been used and postulated. The problem with DBS, of course, is that it's an invasive procedure, and so it's always has been regarded as very much the sort of last resort. Now, of course, 20 years ago, we didn't have the options that we have today. So, this is in an era before people were using Botox for chronic migraine. This is well before the modern CGRP modulating drugs, the monoclonal antibodies and the GPAs. And so, there was a patient population back at that time that, had been through dozens of kind of drugs from, amitriptyline and beta blockers through to kind of, long shots that worked, in a little case series from a random, American headache center in the middle of in the middle of nowhere. So, there was a real interest at that stage. There is still an ongoing interest in invasive neurostimulation as a headache treatment, but I think it's much smaller scale now. What there has continued to be is an interest in non-invasive neurostimulation. So the idea that changing input from those nerves that feed into that central processing system could be helpful is something that is still actively being worked on. And there are devices. There's lots of sort of toys and devices that come out. But if you look at things like supraorbital nerve stimulation, occipital nerve stimulation, vagal nerve stimulation for the neck or the ear, transcranial magnetic stimulation of the cortex, and even remote electrical stimulation. There's a device that's licensed in the States which gives you a bit of a buzz and a bit of a pain in your arm to distract your brain from your migraine pain. And all of these things, can sort of work. in some cases. And again, they're all based to a greater or lesser extent on the sort of the old theories of gauging and pain. So I think, deep brain stimulation will continue to kind of sort of be there in the background. People are always interested in it. Neurosurgeons love to kind of, prod around inside the skull and do things. And sometimes they come up with useful things like that. But I think it's always going to be relatively small scale. And obviously the advent of the treatments that have come through in the last 10 years, I think has made it perhaps a little bit less necessary across the board to have those sort of, very much last resort invasive treatments.
Well, appropriate time to go into those treatments. And you established, the background was this WHO step-ladder approach to the treatment of migraine. Does this suggest that the approach is rigid, or is that you can kind of jump in and pick and choose?
Well, so the point really I was making with the WHO stepwise ladder. So that's really that's the WHO ladder for pain generally. And of course, for those people who don't know, basically it starts off with sort of simple, analgesics, so paracetamol, non-steroidal anti-inflammatories, and then it goes up to weak opiates like codeine, then it goes up to strong opiates like morphine. So there's a kind of stepwise thing. The point I was making really is that for migraine and for head pain generally, this is not the appropriate thing to be using, because opiates in particular are not good treatments for head pain disorders. There's actually very little evidence behind using opiates, codeine, tramadol, morphine for migraine or any head pain disorders. And of course, the problem that comes with them, there's several problems. Firstly, opiates make people constipated, which is generally unhelpful when people are having migraines, because we get a lot of gastroparesis and gut alterations anyway. Secondly, they often don't work particularly well. And thirdly, the potential for overuse of opiates to cause worsening of headaches, to cause medication overuse headache, is extremely high, whereas, for example, that risk with non-steroidal anti-inflammatories is very, very low. Now, of course, you say, well, that's fine, so don't use opiates. What do we use? And for the last 30 years, what we used is triptans. So the triptans were first discovered by a chap called Pat Humphrey, who worked at Glaxo in the 1980s. But Humphrey was looking for a sort of better, cleaner drug than ketamine for migraine. And at the time, the leading theory was that migraine was modulated through serotonin metabolism within the brain. So Humphrey used a model, the doxyphenous vein model, to try and find drugs that would stimulate serotonin subtype receptors. And he found this drug called GR13075, which we're all much more familiar with as sumatriptan, which seemed to do what he wanted to do in his model. And then once it was given to volunteers, seemed to be extremely good and actually stopping people from having migraine. So sumatriptan was first released to the market in 1990, almost instantly incredibly successful, because it really did work very well and was much cleaner and better tolerated than the ergots. And of course, almost immediately out of that came the work that Peter Goadsby, Lars Edmondson did, that showed that whilst, yes, the triptans stimulate serotonin subtype receptors, the consequence of that is the presynaptic blockage of the release of CGRP, calcitonin gene-related peptide. And it was the rise and fall of that peptide that seemed to most closely accord with the rise and fall of pain in migraine. And it was blocking that peptide and not other candidates like substance P and BIP and lots of other sort of neurotransmitters that people were interested in at the time. Drugs that block those did not block migraine. Drugs that block CGRP did. And that's really been the basis of a lot of the migraine science of the last 30 years. It's been trying to kind of work out the whole CGRP story, where it is, what it does, how it works. And we're still kind of doing that and still trying to work out how this all kind of comes about. And then obviously the pharmaceutical companies reasonably quickly kind of looked at the success of the triptans and said, right, well, look, maybe we should be looking for other drugs or creating other drugs that block CGRP. So the first generation of the sort of new CGRP drugs were the first generation GPANs. These were drugs that were direct CGRP antagonists. The idea was that, you know, the triptans are generally very, very safe drugs indeed, but because they stimulate serotonin receptors, they can cause a very small amount of vasoconstriction. Now, under normal circumstances in healthy individuals, that really doesn't cause any problems, but obviously it does make them inadvisable in people that are known to have had heart disease, strokes, and so on. So there was an interest, even from the very beginning, in finding drugs that would modulate CGRP more directly. And the first generation GPANs never made it to market. Some of them were, financially, commercially unviable. The one talcegepan that made it all the way to phase 3 trials, unfortunately, was subsequently discovered to have caused liver problems in some people, and it was withdrawn. So that first generation of those CGRP drugs never made it to market. I mean, when I was appointed as a consultant back in 2007, I remember talking at my interview, and they said, you know, what's the new migraine? And I was saying, oh, we've got these fantastic new drugs, you know, the trials are out, you know, they're going to be out next year, and it's all very exciting. And they just never came because they were all withdrawn. The CGRP story didn't go away, and it was really the sort of monoclonal antibodies that were created originally as lab tools to kind of locate CGRP in brain specimens. That a bright spark sort of decided that if you had something that would specifically bind CGRP, then maybe that you could use that as a treatment, and so it proved. And so the monoclonal antibodies, all the trials came through in the kind of about 10 years ago, and they were all approved for use in the States and in Europe back in 2018, and obviously on the NHS in the UK between 2020 and 2022. And those have been, enormously successful drugs because their efficacy is very good. At least 50% of people who go on them have a 50% or more reduction in their headache and migraine days, which, is a big deal for people who are that severely troubled by the condition. And they're very well tolerated. The side effect profiles are very benign by comparison with a lot of the old drugs that we used to use before. Now, of course, there are all sorts of logistic issues that, they're relatively expensive. So we have to think about that as a societal burden in terms of the cost. Logistically, being provided by headache specialists, and we don't have enough headache specialists. So there's all sorts of issues that come around that. But it's fantastic to have modern migraine-specific effective drugs that we can use. And then, of course, in the last couple of years, you've got the second generation GPANs, so the oral treatments that, still that same idea that, they target CGRP more specifically. And these drugs are very interesting because, again, they were originally developed to be acute treatments like triptans. But it's been shown that some of them, at least, the more people took them, the fewer migraines they had. And actually, two of the GPANs, rimegepant and atogepant, are licensed as preventive treatments. And so we have this interesting scenario that, people like me for the last 20 years have been telling people not to take too many painkillers because it's going to make their headaches worse. Whereas with the GPANs, that doesn't seem to be an issue. And there's lots of interesting kind of mechanistic questions about why that might be true for them, but not true for the triptans, not true for opiates, and maybe less true for anti-inflammatories.
So a lot to uncover then in the CGRP world.
Yeah.
Which conventional preventatives will you use before you think about going to the CGRP drugs?
So it's becoming increasingly difficult, actually, because the standard ones that we have used for 40 or 50 years and still use today are, the tricyclics, so amitriptyline. You're obviously in much lower doses than people used to use for depression, but they can still be really effective drugs for people. And then you've got beta blockers. Most of the kind of commonly used beta blockers, propranolol, atenolol, bisoprolol, metoprolol, they all have migraine action. And again, they can work really very well. The problem with those drugs is tolerability. Lots of people don't get on with them for various reasons. And of course, there are people that can't take beta blockers because they have asthma or peripheral vascular disease and so on. The other drug that's really sort of come into quite widespread usage in the last 10 years has been candesartan. So obviously that group are angiotensin blockers. Actually, there's also a trial. There's a trial that shows that telmisartan can work. Nobody's ever done trials of the other sartans. But candesartan, I mean, again, interesting story, a chance observation by Lars Stovner's group in Norway of a couple of their patients 25 years ago that were put on for blood pressure and came and told them that their migraines were better. And I suspect that most of us would have gone, oh, that's really interesting. I'm really pleased for you. And then not really taking it on any further. But Lars's group, kind of really ran with that and did two really well conducted and well-run trials that showed that it really was an effective migraine medication. The other interesting sideline of candesartan is that obviously in COVID, the SARS-CoV-2 virus was discovered to bind to the ACE receptor. And one of the pieces of information that came out as part of the research that was being done into potentially how COVID might cause pain or other neurological symptoms was that that was found that receptor was actually expressed in the trigeminal ganglion, which is part of the relay system that's activated in migraine. And so you suddenly have that really sort of interesting link that just comes in, and you suddenly go, oh, maybe that's where candesartan is working, because we know that the trigeminal ganglion, or at least part of it, sits outside the blood-brain barrier. So again, I mean, look, if we're absolutely honest with ourselves and everybody else, we don't know specifically how really any of these drugs work in great detail as preventive. But those are still in widespread use. Now, of course, when I started, in headache back in, 25 years ago, we would then go on to use epilepsy drugs. But we do so far less frequently now. So, and the reason for that is that the drugs that have the best efficacy behind them are sodium valproate and topiramate. And of course, our biggest population is women, because more women get migraine than men, of childbearing age. So we just don't use those drugs anymore. And obviously sodium valproate first of all, and now more recently topiramate, very clear evidence that these are not good drugs to be giving to, women, or even in the case of valproate, probably men, potentially childbearing age. So, those have really fallen out of favor. Other epilepsy drugs that we used to use, like gabapentin and pregabalin, I think have pretty conclusively been demonstrated actually really don't work very well for migraine. I find them very useful for neuropathic pain, but not really for migraine. Then you've got old-fashioned drugs, really old-fashioned drugs like pizotifen that are still around, but obviously, again, can cause a lot of side effects. So this is a bit of a problem now because, as many people will know, on the NHS, if we want to move on and use Botox injections for chronic migraine, or if we want to use the gepants, or we want to use monoclonal antibodies, theoretically, we have to have tried and people on at least 3 previous preventive medications. Now, those, it must be said, there is no evidence that suggests that has to be done. And so that was a kind of pragmatic decision that was made back when Botox was being approved for use on the NHS, 15 years ago. But that's what came out of that, and we're kind of stuck with that now as a concept that that's what we should be doing. But it's quite difficult to do now because 10 years ago we would have given pretty much everybody topiramate, and we probably give lots of people valproate. Whereas really these days, we hardly do. And so most people now maybe have amitriptyline, might have a beta blocker if they can have a beta blocker and candesartan. But after that, where do you go? It's we don't have as many options as we used to, actually for very good reasons. And I think the reality is that over time, what will happen is particularly the new oral CGRP antagonists, the gepants, will start to become used earlier and earlier. And I think the future is likely to be that those drugs will find a much earlier place, and they will probably actually be used quite a lot within general practice, even before people get referred on to people like me for other sort of treatments. And actually, I think that's a very good thing. It'll be a very good thing for migraine sufferers because they're very effective, well-tolerated drugs. But of course, on an NHS side, there are also implications in terms of the cost of that and so on and so forth. But yeah, these things evolve, and with my historian's hat on, you look back 50 years, and the drugs that were regarded as kind of standard treatments, cyproheptadine, clonidine, methosergide, which was a really good drug, but just died, about 15 years ago. We don't use any of those anymore, and probably for good reasons in most cases.
So it might be, or the headache world might borrow from the epilepsy world, where you define drug-resistant migraine as the failure of two drugs, rather than.
Yes, that may happen, and of course, one of the main differences between the way that we manage things in the headache world and the way that well, I was going to say my colleagues manage epilepsy, but I manage epilepsy in my general neurology life, is that we very rarely use combination therapies. So, we do tend to move on from one drug to another and stick with monotherapy. And I mean, there's no good reason why that is the case. That is just the way things have generally been done. Whereas, of course, in epilepsy, it's very different. Yes, you might try a couple of drugs with monotherapy, but if you're not winning, then you'll almost immediately kind of move on to to combination therapies. So yes, I think I do think probably that is going to I think that will change over time. And the topiramate, topiramate is still, as we speak today, is still recommended as the first line in the NICE guidance for management. But again, that's just not going to be tenable as a pregnancy prevention program comes in, and these things will have to change because practice changes over time.
So many questions to ask, but I think we'll probably I've taken a lot of your time already. One last thing, which from reading your book seems to be emerging, which is this pituitary adenyl cyclase protein. Is it PACAP or PACAP?
PACAP.
PACAP.
Yeah.
It said you said CGRP is not the only game in town. What is PACAP? What is it promising the treatment of migraine?
So yes, pituitary adenylate cyclase protein is PACAP for short. It's much easier to say PACAP. So basically, we know that. Firstly, we know that not everybody responds to CGRP modulating drugs, and of course, part of that is a non-specific effect of poor absorption or rapid metabolism. There's lots of reasons why people may not respond to drugs. But there are clearly people in whom CGRP pathways, which are so important for so many people with migraine and also cluster headache, are not actually as important as they are for other people. And so there has been an interest, there's been an ongoing interest in looking, at relevant brain areas. So particularly areas like the trigeminal ganglion, some of the brainstem areas that modulate, that sort of have that descending control of the, trigeminal complex and so on. And looking to see, are there other neurochemicals that are expressed in these areas that might be relevant? And PACAP has been the one that really has shown some promise. So we know that PACAP is involved in trigeminal signaling, in the same way that if you give people with migraine an infusion of CGRP, it will induce migraine attacks in a significant portion of those people. You do the same with PACAP and you get the same result. So again, it seems very likely that it is involved in those pathways in a significant proportion of people. So there have been drugs that target that pathway, and they're now in late stage, phase 3 clinical trials. Phase 2 trials were positive, showed promising results, looking very similar to the triptans and the GPANs in terms of response rates and tolerability. So these drugs will, I think they're going to be the next sort of thing that comes through from the science into clinical practice. And I think, sometime within the next 3 to 5 years, I think we will probably have the first of these drugs coming through. And I think it will be very interesting because, as I say, there are people that, even under the best circumstances, do not respond to CGRP modulating drugs. And for those people, will these be good options? Well, we'll see. It'll be very interesting to see, but they may well be. And again, it's useful across the board to have, from my point of view, it's very useful to have as many options as we can. And it's also, really important that we keep, we don't sort of think that the story's over with CGRP, because it really isn't. And I think the other area, that I think is going to be very interesting over the next 10 years to 15 years maybe is the whole question of the endocannabinoid system, and how that may also be an issue. So there's some interesting early proof of concept studies for drugs that modulate endocannabinoid receptors and tone as potential migraine options. And so I think that's going to be, the story. The story of the last 30 years has been CGRP, and that's it's still playing itself out. But the next 30 years, I think there's going to be other things that we're going to be interested in. And those historians of 2050 might look back at the 2020s and 30s and say, yeah, that was the era of, X or Y. And then they might kind of look at us a little bit quizzically and go, gosh, you were still sticking botulinum toxin in people. Why were you doing that back then?
Well, that's highbrow. Coming lowbrow, things that will probably not change. What 3 lifestyle changes do you recommend to your patients with migraine?
Yeah. So, I mean, most of the time, I don't have to recommend lifestyle changes to my patients with migraine, because people with migraine are usually pretty good at recognizing what is a good thing to do and what is not a good thing to do. I think the main things, if you can achieve them, firstly, simple things like hydration. So, we all drink too much coffee and not enough water. Yeah. And I think we should all be, most of us, not all of us, but most of us could do with hydrating ourselves better. Migraine definitely thrives on dehydration, and actually caffeine, whilst it can be helpful as an acute treatment, again, overexposure to caffeine can make people more headachy. So that's a simple thing, no more than a couple of caffeinated drinks a day, and try and drink, 2.5 to 3.5 litres of fluid, depending on how active you are, number one. Number two, migraine likes people to be a bit boring. It likes people to eat regularly, to sleep regularly. So if you can keep to a routine, and particularly with sleep, then that's good. Now, of course, these are not necessarily straightforward things to do. Modern life does not necessarily lead itself to keeping strict hours. And what you don't want is people to kind of go overboard and try and kind of live, a too strict a life. And you do see this, and in some ways it's almost as bad as the opposite, where people kind of let migraines run riot. So again, if you can keep to a sort of sensible routine, making sure that you don't miss meals, try and have a kind of reasonably stable and set sleep hygiene routine, that's also helpful. So that's number two. Number three is most of us spend a large proportion of our lives doing what you and I are doing just now, which is sitting in front of computer screens.
I saw that coming.
Yeah, and this is all about posture, and this comes back to almost where we started, really, which is talking about the neck. It's really important that the neck is not the be-all and end-all of headache in any shape or form, but it is a really important component of things. And we do spend a lot of our lives these days with our head kind of bent over phones or laptops. And it's very important to try and make sure that actually particularly if you are a headachy person, if you're someone that gets migraines, that you reduce the impact of that as much as possible. And so it's very helpful to make sure to simple things like making sure that your screens are raised, making sure that you have your built-in breaks, 5 minutes in the half hour, 5 minutes in the hour, to get up, stretch out, rehydrate, and then go again. And of course, there's lots of good evidence that if you do that, then it makes you more productive anyway. But it's those long periods of immobility which are just not good for us, and migraines, will thrive on that. So that's the third one. Those three will do for starters.
I will tell my next guest that we're going to take a break after 30 minutes. Missed the boat with you. Are you writing any book at the moment, or any big project? So
I've got a couple of possibilities that we're considering. So I'm very interested. Well, I've got one that's kind of sort of serious, and then one that's a bit lighter. So the serious one is that one of the other things that I have done over the last 5 years is I have worked for a medicinal cannabis clinic, and I'm really interested in writing about that, and trying to write a sort of honest and straightforward book about what that can and can't do, because I think it's becoming a very big business in the UK. I think there's a lot of hype about it. There's a lot of misunderstanding about what it is. So I think that's an area that I'd really like to try and explore. And I think probably there would be a need for something that's kind of balanced and straightforward. So that's the sort of serious one. The light-hearted one is last year or early this year, Diana Davison, who's now ex-Tory MP, very brave woman who came out, resigned from her job as a minister because of her chronic migraine, and has now left Parliament. Diana actually managed to instigate a debate in the House of Parliament on migraine and headache disorders, which is the first one since the early 1960s. And I was lucky enough to attend, and it was very good. And there were some quite prominent people that came and spoke very well. As a historian, I thought interesting to look back and see, what they were talking about back in the previous debates in the 1960s. And what I discovered is that one of the things they were talking about was an entity called the Putney Migraine Clinic. Now, I'd never heard of the Putney Migraine Clinic, never heard that such a thing had existed. And I started to look into it, and there's an extraordinary story that is begging to be told about this clinic, because it was essentially set up in Putney, as the name suggests, by a philanthropist who was working in a health centre, and she got in a kind of Harley Street specialist to come and see patients with migraine free of charge and sort of try and treat them. Now, the Harley Street specialist was a slightly left of centre guy who had some very odd ideas about migraine, and clearly thought that he had discovered the secret for migraine and was going to end up picking up his Nobel Prize in Scotland, in Stockholm, not Scotland. And it could never, of course, it never quite worked out like that. But so that's the other project that, in the back of my mind, I think that the history of the Putney Migraine Centre would make it would make an entertaining read, and quite a good film as well. So maybe that will be my other project on the side for the next 12 months or so.
Okay, we might bring you back to hear about it. Last question. What 3 books would you recommend on migraine or about the brain generally for listeners?
Well, look, for migraine, there is really only one book that has stood the test of time, as a sort of popular read, as opposed to kind of Wolf's Headache. And that's Oliver Sacks's book on migraine. It's an extraordinary book, and actually, if you Sacks is an extraordinary character. Was an extraordinary character. If you read his autobiography, the second bit of it in the book On the Move, it describes the whole circumstances around the writing of that book. Which are extraordinary and contain a lot of descriptions of the effects of consuming large doses of amphetamines, which he was experimenting with at the time. Out of it, he produces an extraordinary book which has a wealth of clinical detail and observations. And whilst Sacks doesn't really get the best press in the sort of in the formal headache world, you're all a bit jealous of him, really. But it's a beautiful read, and again, it encompasses so much of the experience of people with migraine. And as I say in my own book, that really, what I wanted to do was to try and produce something, similar for the 21st century. And I don't pretend to be a writer of his quality, but that's, it's a beautiful book on migraine. I think the other, if you're thinking more generally about neurology and brain issues, I think the Diving Bell and the Butterfly, the French journalist's extraordinary account of his experience of locked-in syndrome is something that I think all well, I think everybody should read it, but I think all neurologists should certainly read it, just to sort of get in just that smallest insight into what it is like to live within a sort of completely alien world that some of our patients inhabit. So that's number two. And then I think the third set of books that I would recommend to anybody are those by, I think, somebody that you've just interviewed for this podcast series, which is Andrew Lees. I think his books are beautiful. Brain Spotting, The Adventures of Madman, and his little collection of neurological tweets that he's just published. I think they are extraordinary books, and the neurological birdsong. As a historian, I delve in and out of that book, and I'm instantly reminded of the Hippocratic aphorisms. I think they're the same approach to the world and the same sort of timeless quality to them. So I would definitely recommend Sachs, The Diving Bell and the Butterfly, and anything by Andrew Lees as fantastic reads and incredibly thought-provoking, all of them.
I concur totally with number three. I have a podcast on Locked In coming in future, so I'm sure The Diving Bell and the Butterfly will feature there. Okay, Mark Weatherall, thank you very much for participating in this episode of the Neurology Lounge podcast. I'm most grateful. And for listeners or viewers of this podcast, if you found it interesting, you want to check Mark's book. And after that, then you can check my book, Surfing the Brain. And for things more academic, I have a website called Neuro Checklist. And to make sure you don't miss the next episode of the podcast, why not subscribe to the iTunes, YouTube, or Spotify channels? Until then, thank you very much. And Mark, thank you very much for your time. I really appreciate it. And I've learned quite a lot today.
Well, that's a pleasure, Ibrahim. It's been fantastic to talk to you. Thank you.